Kia ora koutou, hui mai tātou. My name is John Ryle. I'm here to introduce our speaker for the Rona Bailey Memorial Lecture. Now, I'm not sure how many people in this room don't know who Rona Bailey is, but Rona Bailey was in Wellington situated communist activist, is how I describe her, who was involved in most of the union labour struggles and other struggles from the 40s through to the 1980s. And Rona has inspired a lot of people, and that is why we continue to have these lectures in her name. Now, in terms of tonight's talk, at a recent Labour History Project symposium, when I say recent, I'm not quite sure when it was now, but it's the most recent, we explored labour struggles in the 1980s, from the high point of the Kinleith strike through to the low light of the Employment Contracts Act. And we covered a lot of things during that period that were important to the development of the union movement. One of the things we did not focus on was the union involvement in the wider struggles for free, comprehensive, accessible primary health care. We started off in 1984 with a campaign for state salaried GPs in low-income areas with free services to people in those areas, and ended in the period 1986 through to 1996 with 8 union health services, 1 in Christchurch, 3 in Wellington, and 4 in Auckland. Now tonight, we're going to explore why these were set up, what have they achieved, and what is their future. We're lucky tonight to have someone who spent 14 years, from 2008 to 2022, working as a practice nurse and nurse practitioner in the Newtown Union Health Service. She specialised in working with refugees, and her skills and experience on the front line have led her to being appointed as a Senior Professional Practice Fellow at Otago University, the Department of Primary Health Care and General Practice, and on to various advisory roles with the Ministry of Health. Her commitment to developing better health services for working class families has also led her to also be involved in the Palestinian solidarity movement, the anti-globalisation movement, rape crisis, the New Zealand Nurses Organisation, and the Lebanese Society of New Zealand. So without further ado, I'd like to welcome Serena Moran to give you a talk.
Thank you very much, John. Thanks for the lovely introduction. It's very kind. Tēnā koutou katoa, everyone. I'm Serena, as I've been introduced. I'd just like to say quickly that this, you can all hear me all right, this, I've kind of got a slideshow going along with what I'm saying, but it could be a bit distracting. So you can either just kind of listen to me, or you can, I've kind of summarised what I'm saying on the slides, but so yeah, that's kind of how I'm using and put some photos in. So firstly, I'd really like to thank the Labour History Project for inviting me here tonight. I want to acknowledge the Te Aotearoa as the tangata whenua of this land we share this evening, and I want to acknowledge all of you who have come here tonight, both in the room and on Zoom. When I was invited to do this talk, I was still working at Newtown Union Health Service. Because of COVID-19 postponements, I've since left, so researching and writing this talk has been timely. I'm just going to get some water to start with. So, has been timely. It's given me the opportunity to reflect on my experience and where to from here for the Union Health Service movement and model of care. I did think as I got deeper and deeper into the subject matter and complicated it, one of my specialties, that John Ryle should have been doing this talk. But here I am and I will do my best. I'm very grateful to the people who started the Union Health Service movement and to those who have documented its history, in particular Don Matheson, Kathy James and John Ryle. Documenting history is important as we can learn from it and either replicate it or learn never to do it again, ideally. I also wish to acknowledge those who have come before us and those no longer with us, in particular Rona Bailey, for whom this lecture series is dedicated. Acknowledging those that have come before us is one part of Māori culture I love. It's connecting the past, the present and the future. This brings strength and purpose for the present and inspiration and hope for the future. The history of the Union Health Service movement speaks to the intersection of the past, present and the future, and the repetition and connections of themes and goals over time. I'm not a historian by trade, nor was I involved in the setup of the Union Health Services. In fact, I didn't come along until 19 years later. So this talk is simply my interpretation of the events past, from what I've read, been told and experienced along the way. Because it's my interpretation, it's important you know from whom and where I come from, and my story, so that you have a context in which to place my retelling of the history of the Union Health Service movement, and in particular Newtown Union. And I'll get to that in one moment, but let's just have a quick look at what I intend to talk about tonight. So I'm just going to talk a bit about my journey briefly, the social and political context at the time that the Union Health Services were set up, the members in the unions and what they did, an alternative model of healthcare, the impacts over time on the Union Health Services, whether the model's still fit for purpose, and then I'll conclude. Because my experience was at Newtown Union Health Service, then that's predominantly what I talk about, especially a bit later on when I'm talking about the model of care, but it's similar across the Union Health Services. So I grew up in Wellington in the 1980s and 1990s. I come from a Lebanese family who migrated to Aotearoa at the turn of the 20th century. Always proud of our Lebanese heritage, my family was always concerned with social injustice. From Palestine to gay rights, to women's rights, to colonisation, to racism, I knew there were wrongs that needed righting. So it's not surprising that I became involved in social justice movements as I grew. Social justice led me to nursing. I hated inequity, I liked people, and I wanted them to realise their potential. In 2004, I graduated from Massey University with a Bachelor of Nursing degree, and not long after, I knocked on the door of Newtown Union Health Service. I sought out Newtown Union's health service. Why? It's a not-for-profit, union-affiliated, embedded in the community and working with Māori, Pacific and refugee background communities. I left in March of this year, 14 years after I started. What I have learned over those years, particularly from colleagues and patients, is vast. The tangible things I now have are nursing experience working across the lifespan and a specialty in refugee health. In 2018, I completed my clinical masters, and in early 2019, I became a nurse practitioner. A nurse practitioner is an advanced nursing role. Aotearoa's first NP graduated in 2001. There are now approximately 600 of us across the motu, mainly working in primary health care. We provide assessment, diagnosis and treatment. We are prescribers under the same legal framework as doctors. Because we are nurses, we bring a whole person approach to our work and weave the nursing and medical skills together for the benefit of our patients. I was a workplace and national delegate for the New Zealand Nurses Organisation and remain a proud member. Good health is the ultimate determinant of realising one's potential. If your health is compromised, it affects your potential. The degree of the impact is variable. In 1978, across the globe in Kazakhstan, the World Health Organization held a global conference on primary health care. From this emerged the Alma-Ata Declaration, a major milestone in the field of public health. It identified and called for urgent action on a universal goal, health for all by 2000, and identified primary health care as the key to attainment of that goal. It reaffirmed health as a human right and defined it as a state of complete physical, mental, and social well-being, and not merely the absence of disease. It linked health with wider social determinants such as employment, income, and housing. Back in Aotearoa, change was afoot. The late 1970s and early 1980s saw cuts to health and social services. The 1980s continued to bring huge social and economic change. Neoliberalism brought rising unemployment, cuts to social services and benefits. The 1980s was beginning to see the increasing widening of inequality. At this time, apart from a few iwi-based health service initiatives, primary healthcare was delivered by small owner-operated private businesses run by general practitioners. They largely operated on a fee-for-service model, introduced in the 1930s under the Social Security Act. Every time a patient was seen, the doctor received a payment from the government. Initially, the fee covered the cost of the service, but increasingly it didn't. This saw a move by the general practices to take co-payment from patients. This meant that primary healthcare became increasingly expensive. As social and economic inequality widened, low-income workers increasingly identified healthcare access and cost as issues. For Māori and Pacific people especially, utilisation of primary healthcare services diminished. The Northern and Wellington Hotel and Hospital Workers Union, affiliated to the Labour Party, had been active in opposing the closure and privatisation of public hospitals under Muldoon's national government. They had a deep commitment to publicly funded health services and saw this as part of a social wage. Just prior to 1984, this union, along with the Caretakers and Cleaners Union, conducted a survey of members, mainly low-paid women. Members identified the unaffordable cost of health service for their children as being one of their main concerns. As a result of the survey, union organisers approached the newly elected Labour government and asked if the government would consider employing salaried GPs, much like they were doing in hospital-based health services. In response, the then Minister of Health, Michael Bassett, proposed legislation to double doctors' subsidies for children in return for general practices capping co-payments to $2. Supported by the New Zealand Medical Association, a group of outraged GPs took the government to court, arguing the fee cap contravened the Social Security Act. Union members mobilised and protested outside the Medical Association offices to garner publicity for their campaign. This resulted in the Minister of Health offering some funding for the union to set up their own low-cost health initiative. The funding would be available for 3 years and act as a pilot for a new funding framework. Capitation funding, essentially bulk funding a practice based on their patient population. It was already in existence in approximately 3 practices in the country. The funding was a promising start, and the unions began debating how best to set up the health services. There had been some debate in the Wellington Union movement as to whether unions should incorporate private health insurance into their national awards, or whether it was the responsibility for the government to provide fully publicly funded primary health care with all doctors salaried. The idea of a union setting up a health service, some feared, could take them down the private health provider route. The unions based in Auckland set up a private company and started Otahuhu Union Health Service in 1987. The Wellington unions worked with the Council of Trade Unions, the Newtown Community Health Association and the Wellington Hospital Board to start up a union health service in Newtown, which was run by members rather than the union. Unions led education sessions for members encouraging them to sign up to the Wellington Unemployed Workers Union or the New Town Community Health Association to be part of determining the direction of the new health service. In May 1987, New Town Union Health Service opened. It enrolled union members, the unemployed beneficiaries and their whānau. Subsequently, other union health services were established over the years in Otara, West Auckland, Hamilton, Christchurch, Porirua and Lower Hutt. Most continue today. In 1993, the Union Health Service Centres formed a national office to provide strategic management and coordination for the 8 Union Health Centres. In 1994, that national office reconstituted itself as a national network of non-profit primary care providers called Healthcare Aotearoa. Healthcare Aotearoa aimed to provide a support network for its member organisations. So what was the model of care provided by the Union Health Services, in particular Newtown? How did it differ from that already on offer in general practice? A move away from general practice and towards primary health care was a radical change. As the Alma Ata Declaration in 1978 had espoused, primary health care was a human right, a vehicle for wellness, community development and participation, a process or journey rather than a one-off static event. Capitation funding, it was thought, could provide more flexibility, planning and vision for new models and ways of working. It provided an incentive to keep people well. It was later implemented across primary healthcare services with the advent of the primary health organisations as part of the then Health Minister Annette King's primary healthcare strategy in the early 2000s. Those who enrolled in the Newtown Union Health Service were automatically members of the incorporated society. The governance structure included representatives from unions, community groups, iwi and staff. The model promoted biculturalism, Māori were involved prior to the commencement of the Union Health Services. Advice was sought from local iwi and others, and alliances were discussed. Māori were represented on the management board. Kaumātua provided direction and advice, and Māori workers engaged with their communities. Pacific communities were involved from the beginning. They were representatives of members of the union involved on the management committee of Newtown Union and as staff members. The service worked closely with groups within the Pacific communities. Traditionally, in general practices, nurses were employed by the GP business owners. The Union Health Services developed interprofessional teams, including community health workers, social workers, language interpreters, and midwives. Nurses were enabled to work to the top of their scope of practice as autonomous practitioners. The midwifery service was unique and provided seamless and integrated primary health care for women, pregnant women, and newborn babies. Care was delivered according to community needs and aspirations. Outreach clinics and council housing complexes, rugby clubs, workplaces and community halls were set up. The service intended to be flexible and responsive to need. When it was identified that patients were not attending specialist appointments at the hospital, Newtown Union facilitated specialists coming to the clinic and seeing patients there. This not only provided a safe, familiar place for patients to see a specialist, but also upskilled the primary care providers in the clinic. The advent of Newtown Union coincided with the deinstitutionalisation of people with severe and enduring mental illness. Newtown Union took on the care of this group, working alongside accommodation providers, drop-in centres and secondary mental health services to provide wraparound care. This integrated mental health into primary care with the aim of reducing stigma and working with people rather than diseases. Newtown was and remains a suburb where migrants and former refugees settled. These groups were often not served by the traditional model of general practice, so Newtown Union became their provider. Newtown Union was one of the first practices in the country to utilise language interpreters. They grew their own interpreters due to a lack of professionally trained ones at the time. Newtown Union has become a national leader in primary healthcare provision for former refugee communities. Primary healthcare is inherently political, so advocacy and lobbying are essential. Healthcare Aotearoa provided a national mechanism for lobbying and advocacy. Staff alongside communities agitated politically for patient health needs and access to the wider determinants of health, such as housing, income, education, adequate service funding and the benefits of the model of care. Economic reforms continued unabated into the 1990s and beyond. This created funding uncertainty for the union health services and stunted their growth. Opposition to the model from the power bases in general practice continued. Workers in the services became ground down. Peak efficiencies meant there was no fat left in the system, nothing left for innovation or responding to changing needs. The union health services have not been immune to the effects of neoliberalism. Profits at the expense of people and their health, alongside the effects of colonisation, drive poverty and long-term conditions such as diabetes, addiction and respiratory diseases. Rampant individualism and social pressures result in increasing mental distress. Patients have become more unwell with more complex, multifactorial needs. As people struggle to make ends meet, they lack the time and energy to invest in community initiatives and movements and to be partners in their healthcare. Capitation funding did not keep pace with increasing complex social and medical needs and has, in a recent study, been found to be structurally discriminatory. Weighted for age and sex as predictors of health, it does not consider the younger age distribution of deprived populations. Even if one considers additional funding formulas, overall funding remains disproportionately low for practices working with low-income and deprived populations. Funding restraints meant that valuable services like midwifery services were lost. Also, the ability to provide care to new refugee arrivals was compromised at some services with funding insecurity and cuts to contracts. The loss of healthcare Aotearoa meant there was no longer a national voice for the union health services and not-for-profit health services generally. Healthcare Aotearoa's demise seemed to be a triumph of managerialism, another political force at work. Grassroots political organising was in fact a central part of the union health service movement. This was the driving force behind its creation, and it's sadly something over my time in the service that has been lost. When political organising is lost, the connections of health to the wider social determinants is also lost. So too is community development, and then you're back to a fragmented, disjointed, transactional style of healthcare. Also, community involvement in the service was reduced, facilitated in part by a change in board structure and service membership criteria. While the lower fees and community-based service provision of the union health service movement resulted in improved access to care for some low-income workers and those on the margins, some would conclude the overall impact has been minor. This is evidenced by the appalling health disparities for Māori, Pacific and poor people across the health system. So are the union health services still fit for purpose? In my opinion, the philosophy remains fit for purpose. Community-owned, accessible, affordable, quality primary health care delivered by an interprofessional team of unionised workers. But what's missing and what needs changing? The COVID-19 pandemic has uncovered a stressed health system with an inadequate and undervalued workforce. Primary health care, increasingly corporatised, continues to receive crumbs in terms of the percentage of the health budget and essentially maintains its role as an ambulance at the bottom of the cliff. So there are, of course, structural issues which need addressing. How can the union health services collectively raise their voice with some solutions? A weakness of the union health service model, in my opinion, is that it lacks methods of evaluating how the model improves people's lives, health and quality of life. It may be small improvements, large improvements, it doesn't matter. But to be able to advocate for the model, we must be able to tell the stories and produce some evidence of benefit above that which could be obtained from mainstream services. The union health services have been slow at embracing advanced nursing roles. Nurse prescribers and practitioners provide invaluable skills for the populations union health services are trying to reach, and they need to be considered in workforce planning. How the union health services work with Māori members and patients and alongside iwi health providers into the future requires attention. Many Māori and iwi health providers are building innovative and contemporary primary healthcare initiatives, and it is likely the new Māori Health Authority, Te Aka Whai Ora, will provide strength and cohesion to such initiatives. Increased community involvement in the direction, aspirations and priorities of the Union Health Services is essential. So in conclusion, my journey with Newtown Union Health Service has exposed me to the struggles of people constantly up against the system, the tangible impacts of colonisation and racism on Māori lives, the post-migration stresses such as poor housing, unemployment and discrimination former refugees face as they settle into what they thought would be better lives. I learnt what it means to be a survivor. I learnt that sometimes it takes years of walking alongside someone before they trust you enough to take your medical advice. And I learnt the beauty of working interprofessionally, the mutual support and growth this brings. The history of the Union Health Service movement tells a story of vision, people power, collective organising, political action and change. It's a story of relationships, connections and trust. Although not perfect and in need of some introspection and refresh, Union Health Services are as relevant today as they were in the 1980s. The vision they had of quality, affordable, acceptable, appropriate and accessible primary health care across communities for those most in need has still not been fully realised. There is still work to be done. This story provides the hope and inspiration to continue that mahi. Ngā mihi kia koutou katoa. I'm happy to take questions or comments. So that's my opinion too. So you know,
Kia ora.
Kia ora, Louise.
My name is Louise, a colleague. In a sense, I work in public health. So I just found your talk really absolutely fascinating. I, have always known about the Newtown Health Service and generally, but not in the kind of detail that you've traced. So thank you so much for that. I just wondered about your comment on recent restructuring of the health system, as exemplified in the Paiora Bill, the Paiora Act now. And what was deeply disappointing to me was the lack of any sense of vision in the restructuring for primary health in general. It strikes me that primary health care is incredibly fragmented, difficult for anybody to understand, even a health person. And I just wonder if you had been in charge of primary health in our new health structure, what would you have done differently?
I was really hoping someone wouldn't ask me that question. Well, I think you're right. I think that primary health care is always left out. I can't kind of understand it because it's the door to health services. It's the place that everyone goes to. So I think if I was in charge, you'd have a hell of a job on your hands. But I think I would start with the problem is, I suppose, for those in charge, the problem is they're trying to balance, this kind of increasingly technologized health system with huge expectations of what people want and need, and ever-growing sort of expectations cost. But I just think you would actually need to shift. You can have all that, but you need to shift the focus onto prevention. Like, there's no prevention in the health system. There's like health promotion, prevention, working in communities. We talk about food or we talk about diabetes. I mean, all those things. There's no. You can only start to change that if you are in people's lives. Like, the other thing about health is it's everything else. It's the determinants. So if you have poverty, if you have inequality, then you're going to, you continue to have cycles of bad health. So you have to address it. And the thing about health is it's fragmented from other parts of it. Like, even when I work in refugee health, there's the Ministry of Health, but then there's the immigration part, the housing part, the education part. Like, they all need to marry up and work together. But I think you're right, primary health care is always left out. And I think partly it is because it's so fragmented. And I also think there's interest groups in primary health care or general practice that get listened to and are at the table. Nurses are not at the table. We're never at the table. So that's also an issue. And higher up in those health reforms, there's very few nursing voices. And we're often the ones that are on the ground with people, you know. Doctors are too, but yeah. And I think that the general practice part of primary health care is what is at the table, and they have their opinions. And that's been incredibly, that's kind of a corporate model in a way. Businesses, like, wanting to make money. So, yeah.
Oh, thanks, Serena. Every time I hear the story of Newtown Union, I learn some more. I'm a former chair of the board at Newtown Union, and still warming a seat there under the new chair. Look, some of the points were really resonated for me, particularly around being able to demonstrate the value add, I guess, or the difference that the Newtown Union model makes. I think that certainly in my time as the chair, we were very acutely aware that we didn't do that. We weren't able to tell that story, as you say. Yeah, and other points that you've made as well resonated. One point about the changing structure of the service, a point which should be recognised is that was driven in part by legislative change. So, for example, Newtown Union Health Service is now owned, that's the practice, owned by an incorporated society, which of course is governed by the Incorporated Societies Act, which has recently been updated. And so some of those legislative changes have driven changes in our structure. But one thing which I would just end with, a little plug, one of the changes to the Incorporated Society, which owns Newtown Union, is that we've recently, in the last year or two, opened up membership to any supporter of the aims of the service. So anyone here tonight who'd like to join that Incorporated Society can do so by visiting the website nuhs.org.nz.
Yeah. I think another thing that this made me think of too was what's the union's role in Newtown Union Health Service, or the health service movements now? You know, how do trade unions, you know, what's their role in them? Because initially they mobilised people, you know, it was the members that started that. So how does that kind of continue that work? Yeah. But that's kind of the political organising bit, and I think that's been lost. Yeah. And I think that's a shame, because I think that's the key to an effective health service, is that you have your health service, and then around it you have this kind of community development and political action. That's, you know, someone comes and sits in your clinic, you can only deal with a very small part of that person's life. But if you can help to advocate, you know, for their housing, or their, you know, for better wages, you know, living wage, things like that, then that also helps. So, yeah.
I've got a question.
I think what went wrong is, I reckon neoliberalism has kind of promoted this kind of, I don't know, I just find, like, when I first started at Newtown Union, I think it was really good to be political. Like, that was really part of being there. Like, you were political, and I just think over the years, that became less, I don't know if it was less palatable or less, you know, that kind of, it's like that culture of you don't complain, you just sort of find solutions, and you don't, you know, that kind of culture. I don't know, I think it seeps into the society a bit, and it's kind of all around us. Yeah. And maybe people get ground down as well, and the funding, and you're trying to constantly kind of grapple with these changes and making ends meet, and, you know, the service, I mean, not to mention the people's lives. Yeah. But it didn't go wrong, because that model still exists. Like, all those cool things that were being done are still being done. But I'm always thinking, you know, what could be better? How could it be better?
I've got a question. It seems like what you're talking about that's different is the model of ownership. And I remember vaguely reading some New Zealand history about how the hospitals got set up from private hospitals. They got nationalised, basically, because the government had the infrastructure money, whereas the GPs fought back and stayed private. And would you say that it is that is the problem with why the primary health care is not getting the attention in these new changes that are going on?
Actually, that's what I'd do if I was in charge. Yeah, I'd nationalise primary health care.
I'd nationalise most.
You said it, yeah. Sorry, it's sort of stating the obvious. I would. Some people argue, oh, no, you don't want to do that because more people will attend and people just go to the, the doctor or nurse because they... But that's where if you have a well-resourced primary health care, then you deliver health in all different ways, promotion, prevention, in communities. Yeah, absolutely. Because otherwise it's so fragmented. Like, everyone does it differently. Every little practice that's set up has to do all these things. Like, there's so many systems. It's so many systems because you're interfacing with the community, the hospitals, the nationalise. Yeah, I think so. Yep. I'll go away now. I should put the references up. Like John Wright.
My job is just to thank Serena very much for what she said. I think there's a long history to these services. The unions didn't want the services. They wanted nationalised primary health care. They wanted salary GPs employed by the state. However, once they were set up, in fact, these services, like all union and labour organisations, require vision. And they require a renewal of activists who come through them, who have got ideas and passion. And sometimes, at various times, you see this with unions. They actually lose their passion. They were set up on with people who are driven, and they did some great things, and then those people leave, others come in, and they go back to ground zero. When we set up Newtown Union Health Service, the people who are involved, and Hazel Armstrong's here, who was one of them, when it came to employing the first GP, we just wanted to set up a cheap general health service, a primary health service. We called it a cheap GP service, where our members wouldn't have to pay very much. We instead got these GPs who turned up for an interview, Don Matheson and Julia Carr, who said, no, that's not what you want at all. You want a primary health service. You want to unionise health. You want to make sure that so-called patients, our members, are driving it. And so we employed them. But it's just the point I'm making is that these cycles happen. And I think that Serena's made some very good points about research, about actually the narrative of what you're doing, instill a narrative in all your staff. Have a governance board that's driven by the people who are members of the service. Start calling people members rather than patients. So the control that's exercised by the clinician is more the control of the member of the service who owns it. So those are my comments. I'd just like to thank Serena very much. I think it's a very interesting topic, the relation between unions and wider struggles. And I can hope we have more of them. Thank you.
Thank you.